Actually, no. I know what I gotta do. Just close this over here. Put this up. Close that over there. I gotta bring it back over here.
Good morning. Can you hear me?
Can you hear me?
Yes.
Great.
Can you all hear me?
Yes.
Okay. How's it going?
Good. How are you?
I'm good, thanks.
Hey, everyone.
Good morning.
So Ladarius, it was that file was too big on my side. It says it was too large.
I don't know.
Yeah.
That was strange because Christopher was able to open it.
Mm-hmm.
I am about to try to. Am I going first? I didn't know what the run of show was.
Well, it doesn't. Well, it says Christina. How you doing, Christina?
Good.
And then Ladarius, and then Keith, Dr. Keith.
Okay. I was just wondering either way. What I'm gonna do now is attempt to open it. And like I said, I was able to share yesterday. So hopefully,
I know this technology. Ugh. Well, we will be in person next year. I can tell y'all that now. We'll be in person.
Oh, that's nice.
Because this is some, as they say, some bullshiggity. So, Dr. Naylor, I'm gonna try and see if I can share your thing too, because it's not allowing me to. Let me see. Okay, I think. Let me see. Can you see this? Share. Can you guys see that?
Yeah.
Okay.
I should be able to share my own screen too, right?
Yeah. You just hit share. Oh, now it's going back. Okay. I'm going. Okay, let me get back to where I was at with y'all.
Just, I think my share icon is X'd out, so I don't know if we have the authorization.
That's how it's supposed to look.
Oh, is
no,
it?
that's just how. Yeah, and then because it's like that, and that lets us know that we still have enough to share. If we have 5 people in the room, one of us will have to come off screen so we can share.
Right.
You guys see that when I just pulled that up?
What did you just pull? Do it again.
Okay.
And I'm gonna stay off screen until yours came up. There's much more to the story.
Yeah, even though that's the last slide.
Okay, now it's moving. You moving? Diabetes.
Okay.
Okay. And Dr. Naylor, were you able to see what I try to share, guys?
Yeah, my slides came up briefly. I also have them on my my computer desktop if there's any issues.
Okay, well, I'll let you take it away, and if any technical, if yours stopped, then I can jump in. Is that okay, guys and girls?
Now, how much time do I have again?
Okay, the session is from 9:45 to 10:30. However, all sessions 45 minutes. You want to probably have time for Q&A for the participants, and they're going to put everything in the chat. So, and you all can see the chat while you're speaking at the same time, not to insult your intelligence.
So maybe about 10 minutes to present my presentation.
Correct. Yes. So
Okay.
everybody do like 10 minutes each, roughly 10, 20, 30. And then that 15 minutes, 5 each minutes for Q&A.
Okay.
Okay. So 10 minutes, 5 minutes Q&A. 10 minutes, 5 minutes Q&A. 10 minutes, 5 minutes Q&A.
Sounds good.
All right. We can get started, guys. There's 71 people on. So they you can't see them. They can see you. So we can get started.
Right now?
Yes.
Good morning, everyone. I'm Dr. Christina Wells. I am a family medicine physician at the University of Illinois Miles Square Health Center. And I just want to thank the 100 Black Men for organizing this wonderful event and also for allowing me to participate. So I just wanted to briefly talk about diabetes, something that is near and dear to my heart. And just briefly here, dispel some myths and give some information about diabetes. Diabetes, as we know, is very impactful to communities of color. Diabetes costs about $237 billion in 2017 in direct medical costs. And in 2020, the CDC reported that 34.1 million, or 13% of US adults age 18 and over have diabetes, with over 90% of those persons having type 2 diabetes. And we know that there is increased risk for morbidity and mortality related to diabetic complications. Now, communities of color are at increased risk for the development of chronic disease related to different factors that are social, environmental, and lifestyle. Non-Hispanic Blacks and Hispanics develop chronic diseases at faster rates compared to their non-Hispanic white counterparts. African Americans, this is startling, are 1.4 to 2.3 times more likely to get diabetes compared to white Americans. And Hispanic and Latinx has a 50% chance of acquiring diabetes. African Americans also have higher rates of diabetic complications, including retinopathy, which is eye disease, microalbuminuria, kidney disease, lower extremity amputation, and higher rates of mortality or death. In 2017, the mortality or death rate related to diabetes was twice as high for African Americans as compared to non-Hispanic whites. So what are some of the things that impact this? You know, they're the social determinants of health, things such as education, access, and the quality of education provided, healthcare access and its quality, the neighborhood and the built environment around the neighborhood, the social and community context, and economic stability. We are aware of all impact chronic disease development. So just a little bit about diabetes. I'm just going to go simply through this. You know, there's a couple things that impact diabetes, and that's really insulin resistance, which makes your body not able to utilize insulin. And then there's also an inability for the body to produce enough insulin, and this can result over time in insulin deficiency. Some risk factors for diabetes include things such as obesity or being overweight, having excess abdominal fat, being inactive or sedentary, having a family history of diabetes, race, age, a history of prediabetes or gestational diabetes, and having metabolic syndrome. And so metabolic syndrome is, again, having large abdominal weight, having high triglyceride level. These are things related to cholesterol, having a low good cholesterol level, having an elevated blood pressure, or having elevated blood sugar levels. Some of the major complications of diabetes include atherosclerosis, and that's that hardening of the arteries, and that vascular or blood vessel disease, retinopathy, which is eye disease, neuropathy, which is the disease of the nerves, amputation, and nephropathy, which is that end-stage kidney disease. One of the things that is important about chronic illnesses, especially diabetes, is that it can be prevented and it can be improved through lifestyle measures. And one of the myths that I wanted to dispel is that diabetes is not a sugar disease. So many times people think that diabetes is a sugar disease, and it is actually a fat disease. It is related to eating more things that are high in saturated fats. And those things actually cause more of that insulin resistance, so that insulin doesn't really work well. So eating more plants, more foods that don't have fat in them, more fiber and less fat can actually improve diabetes. So I think for so many years we've been thinking, and processed sugars like those donuts, those cakes, those sugary drinks can have an impact, but it is really, really a fat disease. Exercise, regular physical activity helps to decrease insulin resistance so that the insulin that you're producing works better. And it also it helps to improve how the body uses insulin. Sleep is also really important. I know that we're doing lots of different things and sometimes we skimp out on sleep, but sleep is really important because lack of sleep decreases the amount of insulin that your body produces. And so when your body doesn't produce enough insulin, you have more of that glucose or sugar in the bloodstream. And that causes that elevated blood sugar level. And remember, all foods are broken down to sugar. So one thing I just want to talk about really quickly before I end here is the importance of fiber. Because again, I think that we've misunderstood diabetes a little bit and thought, oh, I can't eat, this, or I can't eat that. But diabetes is really, again, a disease of fat. And so eating more fiber is really, really important. Fiber is what you find in things like beans, like lentils, like fruits and vegetables and other whole grains. And the nice thing about fiber is that it slows the absorption of sugar. It also helps to prevent the absorption of some fats. It feeds the healthy bacteria in your gut, and that helps you to be able to absorb nutrients better, and it's also important for how your immune system functions and how your bowel functions. So we've all heard of probiotics. Well, fiber acts as a prebiotic. It helps to feed those healthy bacteria in the gut. Fiber is also important for normal detoxification and helps to bind and eliminate toxins. This other thing I just wanted to go through quickly is just because it really helps us to understand why fiber is important. Fiber helps to reduce inflammation, and it helps us to feel full longer. So the more fiber we eat, the less food that we're going to eat. That will also help with obesity, which is a risk factor for diabetes. Fiber can also reduce inflammation. And it also helps your body to produce insulin when it's supposed to produce it. So there's much, much more to this story, but I really just wanted to share that it's important for us to understand our risk for diabetes and also to understand how the things that we're doing on our daily lives impact our risk and how we can do things, because diabetes is preventable. Diabetes can be managed. It can be improved if we think about how to work on those lifestyle factors, our diet, our exercise, and our sleep. And I'll throw it over to the next presenter.
Thank you so much, Dr. Wells. My name is Ladarius Curtis. I am the Senior Director of Community Engagement and Health for Westside United. Westside United is an organization that is revolved around 6 conglomerate hospitals that are looking to increase the life expectancy of people on the West Side, particularly by the year 2030. We do this as a hospital-led partnership, creating for a more healthy and equitable future. I am trying to get my slide to move here, and it's not. There it is. Okay. That was quick. All right. So the way we do this is as I mentioned in our mission, I just wanted to express to you the importance of certain things. This map here that I'm showing you is actually a map created by the Robert Wood Johnson Foundation, specifically around the city of Chicago. If you are a young child born in the Loop, just being born in the Loop or in the city of Chicago, your life expectancy is 82 years. If you go 6 stops on the blue line to West Garfield Park, that life expectancy turns to 68 years. And I know if you go 6 stops to the south to Washington Park, or even as far as Inglewood, it drops to about 68 to 65 years as well. That just tells you the type of obstacles that we're up against right now in terms of our health. So I want to make sure that people really get a serious understanding of what we're going through and what we need to do to solve this health crisis. We work with these functions through our 4 priorities, which is health and healthcare, which I'm going to discuss with hypertension shortly, neighborhood and physical environment, which we work with community infrastructures to build walkable spaces and more healthier communities. Also through economic vitality, in which we do impact investing for small businesses on the West Side, and also through our education program, in which we provide resources to CPS schools via our school hub. What I wanted to talk about right now is the high blood pressure in Chicago. Obviously, from our perspective on Westside United, we really focused on a lot of these organizations, or these communities. The West Garfield Park community is right in the middle of the screen. That looks like a small cowboy boot, if you will. That tells you the rate of hypertension. The rate of hypertension there is about almost 47%. It's the one right in the dark blue section. But if you notice here, this color is very similar to all the colors here on the south side, where there's Inglewood, Greater Grand Crossing, Auburn, Gresham, South Deering, Chatham, and all these areas here all also have large issues of hypertension rates. And if you notice, the Loop area here is only 16%, which tells you a little bit more about our crises that we're going through with our hypertension. I really wanted to focus this conversation on Black men, because this is the Black Men Expo. Black men are 57%. And Black women are 56% more likely to have higher rates of hypertension than white and Hispanic adults. Black men in particular are getting hypertension earlier. That is also due to a lot of community and mental stress that's going on. Black men have developed hypertension by the age 55, compared to 54% of white men who have not gotten it by the time they turn 55. Some of these rates have a little bit to do with education. College graduates have a lower rate of getting hypertension, a little less than higher rate of not getting hypertension compared to high school. Those who just have a high school diploma, as well as adults who have been in high school and have a college degree, have a little bit of higher rates. So the impact on racism on hypertension, we really tried to focus on a couple of studies. There was a study done recently that just asked these simple 3 questions, and these were the results. The questions were: do you try to prepare do you prepare for insults from other people when you're leaving home? Do you always feel like you have to be careful about your appearance to get good service or avoid being harassed? And the last question was, do you try to avoid certain social situations and places? The results found that Black participants have higher vigilance than white or Hispanic participants at every point. That increases the vigilance as associated with a 4% increase in odds of hypertension. That means the moment, as an African-American person, as a Black person, the moment you walk out of your doors, you are more likely to have an indicator or an impact of stress that is placed upon you. Therefore, you are 4% more likely to have some type of hypertension or hypertension rate increase. We at Westside United here feel like hypertension is one of those silent killers, and it's almost like a silent form of a gateway drug to a diabetes, to a heart disease, to a heart failure, to the majority of the issues that go on with us today. We try to make sure we look at all aspects of hypertension, not only with African-American men, but also we work with pregnant moms and moms who have just given birth, and we take and birthing parents who've just given birth, to make sure that we really get a sense of how hypertension is affecting their body and continues to affect their body after pregnancy and overall. So I'm going to stop right there, and I'm going to pass it on to Dr. Naylor. And thank you very much for your time, and everyone have a good one.
All right, good morning, everyone. I'd like to thank the 100 Black Men for the opportunity to talk. I'm going to try to share my slides here. All right, hopefully everyone can see that well. I'm Dr. Keith Naylor. I'm from the University of Illinois at Chicago. I'm actually a gastroenterologist. And my part of the discussion today will be to discuss about colorectal cancer and colorectal cancer screening, and specifically its effects on the Black population, and particularly amongst Black men. So just waiting for the slide to advance here. Okay, great. So I have nothing to disclose in regards to financial disclosures. So colorectal cancer, just in general, it is still the second most common cause of cancer death for both men and women, and that's for all races within the United States. It's the third most common cancer overall, and it still causes over 50,000 deaths within the last year across the US as a whole. And it's because it's one of the most common cancer. Without screening, the risk of developing colorectal cancer, about 1 in 20 people would develop it over their lifetime if they didn't undergo any screening or preventative services. Unfortunately, amongst all groups, Black men actually have the highest rates of both being diagnosed with as well as dying related to colorectal cancer. So I'll be spending a lot of the talks trying to focus on areas where I believe we can make better inroads in both prevention and early detection of the disease. So the good thing about colorectal cancer in regards to it is as a disease as a whole is it can be both detected and prevented. So many cancers we think about, like breast cancer or prostate cancer, most of what we can do is detect cancer, meaning we can, when a patient shows up, we can do testing and we can find if they have a cancer. But really, from a public health standpoint, there are only 3 cancers that we can really prevent. Colorectal cancer is one of those, also cervical cancer and skin cancer, where we can actually find areas before they become cancerous, remove them, and actually prevent someone from eventually developing cancer. So when it comes to colorectal cancer, even though it's the second most common cause of cancer death, we have a great opportunity to actually prevent the cancer or find it early and prevent death related to cancer. So with the impact of screening, actually death rates from this cancer have decreased by about 50% over the last 40 years. But unfortunately, not everyone is shared equally in that reduction in death rates, and I'll go through that in a moment. So I always like to bring up Chadwick Boseman, because obviously that's something that occurred very recently, and it's a very untimely death, and we're all familiar with him. I think his situation or story can be really a rallying cry for our community to really focus more attention on this disease and this prevention, particularly not just among young people like himself, but the average risk of being diagnosed with colorectal cancer is around 60. So he was an unusual situation, but because he was someone in the public eye, he obviously was very healthy in general. I think it really does serve as sort of a wake-up call that this is a condition that can be deadly, but also can be prevented. So I always like to put him in there just to open our eyes and kind of open our ears to listen to the rest of the conversation and really hopefully try to pick up the things that we can use in our own lives to protect ourselves and our loved ones. So just to lay the groundwork for colorectal cancer a little bit, the colon is the large intestine. It's, you know, an organ that kind of wraps around our abdomen almost like a question mark. And colorectal cancer can develop anywhere within the colon. And many people are familiar with some of the signs of it, such as like bleeding with bowel movements and things like that. But those signs sometimes only occur when colon cancer is found very close to the end of the colon. And when it's at the beginning of the colon, it can be more difficult to actually detect just based on symptoms. So screening is very important to actually detect and prevent this disease. And actually, African Americans are more likely than other groups to have cancers that are at the beginning of the colon, closer to where the appendix is in the first half of the colon. And that can be more, they could present at a later time because we won't see the effects of the actual cancer until it's become more advanced. So this is just an example of what I see when I do colonoscopies on patients. What you see here is a small polyp, and polyps are the precancerous lesion that can eventually develop into cancers. Polyps are not dangerous themselves, but some of them can have the risk factor of over time, usually about 10 years of growing and actually developing into a cancer. This is represented here on this little cartoon image. And as you go from left to right, you see that polyps will start off oftentimes very small, and then over years, they can slowly grow and they can develop what's called dysplasia, which is the beginning of cancer. And then eventually they can become cancerous, where the abnormality actually invades into the tissue. And that's really when it becomes very difficult to treat from a standpoint of using surgery or chemotherapy. So our goal really in public health is to find people before they develop a cancer and remove that precancerous lesion so it never has a chance to become a cancer. Just as something I find really interesting from a standpoint of African Americans, if you go back to the early 1970s, and this graph shows the risk of death from colorectal cancer over time, in the early 1970s, actually white Americans had a higher death rate than African Americans for colorectal cancer. And then right here at around 1980s, mid 1980s, you start to see the risk of death for colorectal cancer in whites start to decrease pretty significantly. And that actually, interestingly, is right when colonoscopy became available within the United States. But as you can see over time, the mortality rate in African Americans didn't really change until about the year 2000. And interestingly, that's when Medicare began covering colonoscopy. But during this time, for various reasons, things like tobacco reduction, but really colonoscopy was one of the major factors. We've actually driven down the mortality rate. But it's really only until Medicare began covering colonoscopy that we really see a reduction in African Americans. And it goes to show that this disease is not a disease of Black people inherently, but it's really a disease that occurs because we're unable to find people before the disease develops. So the more that we can take advantage of preventative measures, the more that we can experience this reduction as well, and not just have it, you know, sort of this disparity that's developed over time. And one thing I always like to put forth is that when you control for risk factors, Blacks and whites actually have no greater risk of developing polyps or cancer. And it's really just, at least what we believe in public health, it's the differences in obtaining screening or other preventative measures that lead to a lot of the differences in actually cancer development and death related to cancers among racial groups. So this is an opportunity for us to really get in front of this and be able to correct some of these differences, because they're not due to biology, they're due really to healthcare in a lot of ways. So briefly, colorectal cancer screening, it's recommended for anyone over the age of 45 at this time. That's anyone without a family history of disease, even when they're feeling well. And there's multiple tests that are available for colorectal cancer screening. Majority of people either receive stool testing, which looks for either blood or other aspects that could be a sign of a risk of cancer, or colonoscopy, which is the most common test that's performed in the United States. Just really briefly, the stool test is something that people who may not feel comfortable with the colonoscopy or may not have the ability to take a day off of work, it may be a good opportunity for them to get screened. And what oftentimes will happen is you'll receive a small kit at your doctor's office or through the mail. And with that kit, you no longer have to actually handle stool, but the kit allows you to sample stool just using a sampling device. and then to put that into a collection container. And then that will then be tested to see if someone has the risk of colorectal cancer, in which case they may need to undergo a colonoscopy to take a closer look. This test is typically done every year because it's not as sensitive at detecting things like polyps as colonoscopy is, so it does have to be done more frequently. Colonoscopy is a test that I perform where I put a patient was sedated during the procedure, where they're sleepy, and we're able to use a camera to go through the colon all the way to the beginning of the colon and carefully look for polyps or cancer and either remove them or detect them during the examination. And generally, if you don't have any polyps on colonoscopy, you can have 10 years between procedures. So this is the last of my slides. I just wanted to say, when it comes to colorectal cancer, the age of screening starts at 45, but that's only for people with no known risk factor for colorectal cancer. So how do you know if you have a risk factor like maybe Chadwick Boseman may have had? So what you should really focus on is knowing about your family history and whether or not anyone in your family was diagnosed with colorectal cancer, and particularly if they were diagnosed before the age of 60 or before the age of 50. And you actually may be a candidate to begin screening at an earlier age than 45 if you have someone in your family, like a parent or a sibling, who is diagnosed with colorectal cancer at an early age. And then if you do have any symptoms, such as seeing any blood regularly in your stools, or any unusual weight loss or abdominal pain that's unusual for you, definitely talk to your doctor about that, because that can be another way that you can undergo these tests without actually being within the screening age group. So that's a very brief overview, and I'm happy to answer any questions, but I just wanted to go through some of the highlights, and hopefully we can have a good discussion about all the important things that we've discussed up to this point. So thank you very much for the time that I've had.
So we do have questions in the chat, Dr. Naylor. The question is from Michelle Bird. Is propensity, the colon cancer, also heredity?
Absolutely, but so more than 85% of colon cancers are what we refer to as sporadic, meaning someone will not have any known family member that has colorectal cancers, but they can still develop the disease. So the majority of people don't have a family history, but those who do have a family history, their risk is higher than your average person. So not all cancer is going to be hereditary or genetic, but if you do know that you have a family history, it's even more important that you discuss that with your doctor so that you can develop a plan at which time it would be time to begin screening. And not just for colon cancer, but for any kind of really diseases, including heart disease, including diabetes. Really talking about your family history for all those diseases is very important.
Okay, another question. What's number one at a home kit you would suggest?
So some of that depends on the healthcare provider that you see, because different healthcare providers will have different testing kits that they use. The most important thing is not so much which kit that you use, because there are fancier kits out there like Cologuard, which is one of the more recent kits, but really there hasn't really been enough difference shown between the different kits to really make a difference in regards to which one you receive. It's more important that you receive screening at the appropriate time and that your doctor follows up on those results appropriately, not so much which tests you receive.
Okay, this is a question for Dr. Wells. Why is diabetes so prevalent in the African American community, and is it more genetic or dietary?
Yeah, I think the key, and I think Dr. Naylor kind of talked about this in relationship to colorectal cancer, is that, there are a lot of different factors, and I expressed some of those risk factors, but I think part of it is our built environment. And so the access part, a lot of it is lifestyle factors. Mm-hmm. So what we're eating, what we're doing on a daily basis. So how does stress impact that? How does what we eat impact that? And so the access to nutritious foods is really, really important. If you go to our communities, you see a lot of on the corner, you see these corner stores, and these are places where you're getting a lot of processed foods. You're getting things like lunch meat and hot dogs and sausages and bacon, and you're not having access to fruits and vegetables and beans and lentils. And so that can impact and it can directly lead to the formation of obesity, inflammation, which will increase your risk for diabetes. And that's why, especially in the era of COVID, that we think about there are some things that we cannot control, or there are some things that we're working to improve, that we're in the process of improving. But the thing I like to tell my patients are, the thing that you can work on every day is what you're eating, whether or not you're exercising, how you manage stress, and whether or not you're sleeping. Because irrespective of the other factors that come in, if you can work on those things, then you can reduce your risk for diabetes. I've even had some patients who can actually improve or reverse their diabetes by working on their lifestyle factors.
Okay, I got a couple more questions. We still got another 15 minutes for this session, which everything is going just excellent. We got some great questions. Is there an advantage of getting the colonoscopy over the FIT test?
So colonoscopy is what we consider, like, right now the gold standard for prevention, because the FIT testing are intended to detect cancer. They don't really prevent cancer per se. So sometimes people will have a positive FIT test and they may not actually have a cancer. Many times, actually, the FIT test can be positive and they don't actually have a cancer. They may have polyps, or they may have hemorrhoids, or other reasons that the test can be positive. But the test is designed more for the detection of cancer and not for the prevention. So if your goal is for prevention, then the colonoscopy is a little bit more effective at that, because it is able to identify polyps even when they're very small, usually starting at around 2 millimeters. We can detect the polyps and remove them. So it's very good at being able to prevent them by identifying these polyps and removing them. But colonoscopy is not the right test for everyone. So you have to, sort of read up on it and kind of know what your goals are, and also your ability to undergo the test, because a colonoscopy does require that typically you would take a day off of work, you'd come in for the procedure, you'd receive sedation, you'd have to have someone drive you home after the procedure. Mm-hmm. So it's generally a one-day outpatient procedure, but for some people, it's better that you get the right test at the right time than you would wait, years and then eventually get a colonoscopy. So if it's easier at the age of 45 to do a FIT test, then I would recommend that would be the right test to do at that time.
Okay, we got a few more questions.
Sharon. Hi, hello everybody. I'm Dr. Rain. I was supposed to be your moderator, but I had technical difficulties getting on. So I was supposed to say thank you and welcome, especially to my U of I folks, since I'm a U of I Med School class of 1980. So that should tell you a little bit. And I'm representing 100 Black men. I'm on the Health and Wellness Committee. I'm also part of mentoring committee as well. So this is what we wear. This is our hoodie. So I just want to represent. Like I say, I'm Dr. Loris Rain. I've been a pediatrician for about 40 years, but glad to be part of the 100. And I just thank each and every one of you for being part of this and the information that you've given. I couldn't get on because somebody bogarted me off, but now that I'm on, I just want a couple things I wanted to address. You talked about the importance of diet. I don't know what we can do to just reiterate how important diet is in addressing each one of these areas. I mean, me, for example, I do meatless Mondays, for example, where I don't eat any animal products at all on Monday, things like that. Okay. Can each of you, just a little bit, I know you've given some information before. Is there anything else you might want to add to emphasize to our audience how important diet is in each one of these diseases? Because each one of these diseases we all know are linked to diet. So is there anything else you want to add that you didn't say before?
Yeah, I would like to just talk a little bit about it, but I want to kind of talk about something that Dr. Wells mentioned, and it was about the access to food. A lot of our communities don't have that same access to food as right now. I'm sure on the west and south sides, what type of food deserts that we're dealing with, and not only are we dealing with the food deserts, even the grocery stores that we do have a lack of healthy and fresh produce there. We actually, on the west side, we just lost a grocery store in one community, particularly the Aldi's that was on in Garfield Park. So now anyone who lives in Garfield Park has to either go to Austin or has to go to the Pete's Produce, at a very expensive one at that, to try to even just get fresh produce. We believe that everyone knows, and I'm sure all the doctors here, I am not a doctor, but I do have 2 young children, and I always tell them that, your health starts inside out. So it's what you put inside your body that's going to get you the production outside your body. I think Dr. Rayner, I think I'm going to try that with my family with the meatless Mondays and see how that goes. They might beat me up, but that's okay. I can take a couple of beatings for a little while. So to do that, I definitely want to do that. But I think overall, I know I saw something in the chat about how can folks in their community kind of talk about or take advantage of what's going on. Reach out to the folks that are already in your community, not just the FQHCs, federally qualified health centers or your others, but I'm talking about your real partnerships, business organizations, chambers of commerce, any type of organization that says that they're about the community. Make sure that they use and make sure that they have a health and wellness section about what they really want to talk about, because health is really wealth. And the only way for our communities to have a generational health gap and to achieve a generational wealth increase is to have better health.
So just to add a little bit, so, you know, obviously colon cancer or digestive cancers in general, because they involve the digestive system, diet is a very important part of digestive health. And, you know, I think in general, healthy diet, we all kind of have a basic idea what healthy diet is: more fruits and vegetables, less meats, and within meats, less red meat. But one thing I really want to key in on, I think in our community, you don't want to exchange one for the other. So even if I tell my patients all the time, if you're a monk or whatever the female equivalent of a monk would be, who lives on a mountain and eats only the healthiest foods, it doesn't prevent you from developing health-related conditions. So diet is a very important part of health, but you want to make sure you still go and you get all of your recommended health screenings, because diet is not a 100% preventative measure for either the treatment or the prevention of a health-related condition. And just really briefly, in my own family, my father's Jamaican, and he's someone who's very difficult to get to go and necessarily access the healthcare system. And I remember as a kid, he would be taking royal jelly and ginseng and blueberry extract as these ways of trying to, in his mind, sort of be healthy, but yet sort of avoid seeing doctors. But eventually, now he's a prostate cancer survivor. He's had a kidney cancer that was successfully treated as well. So it doesn't, those things, we can't use them as ways to avoid healthcare, but they should be used as ways to maintain or promote our own physical health, in addition to seeing your doctor, in addition to getting the recommended screenings that you should get.
Okay. Dr. Wells, want to add anything?
Yeah, I was going to say, I definitely agree with that. I think that they go hand in hand. I agree that, you know, sometimes in healthcare, and I'm a healthcare provider, I'm a physician, we don't always emphasize the dietary aspects. I also have an MPH in nutrition. And so I think that it definitely helps for us to be able to give advice to our patients. One of the things that we've noted since 2019, more African Americans are interested in healthier diets and healthier lifestyles. So it would be prudent for us to think about ways in which we can educate them and tell them how to get those screenings. That's important. You know, I have a lot of patients who don't want to get colonoscopies for whatever reason. I still encourage them to, and I do a lot of fit tests. And so I think it's important that we're doing our screenings. I think it's important to help people to understand how to have a healthy lifestyle, how to eat. You know, I do, Dr. Rayner, I really promote plant-based diets because they can be very, very healthy, and they can help to prevent some disease processes and help to reverse some. So I think that it's important that we find ways, simple ways to reach our communities and help them in their daily lives to make changes, to help them to manage stress better. Because if we're not doing anything and helping to educate our communities, we're still going to be struggling. So I think even the little ways, meatless Mondays, like you talked about, Dr. Rayner, these simple ways, addressing mental health and all these other factors are going to be important to help our communities be healthier.
Yeah. It's interesting. Dr. Miller, who spoke earlier, has talked about Fish Fridays. That actually comes from the Catholic tradition of eating fish on Fridays. though there's things to be said about fish as well. But as long as it maybe not low cholesterol fish and not fried fish. An interesting question brought up by Thomas Henderson, one of our board chairmen with the 100, was sometimes our community, and it's interesting, sometimes our community celebrates large-figured women, whereas we want to celebrate all body types. Does this contribute to morbidity in our community? And one thing before that, real quickly, another thing we'll talk about, the simple thing is community gardens and home gardens, which we all knew mama, big mama, grandmama down south always had one. So going back to those might be important too. But the idea of how we look at each other physically, sometimes we refer to women as being thick, as being healthy, or a woman who may be heavy, that she's healthy. I think part of it's a perception that we have of how we look at each other in the community. So what do you all think of that?
I would say I would focus less on the individual and more on healthy lifestyle.
Yes.
Because, obviously we don't want to, we have enough negativity in our community or particularly women in particular have experienced a lot of objectification of their bodies. Black women, highest amongst women, I would say. So I think really it's just focusing and celebrating the things about our communities that make us healthy. And historically, like you said, fruits and vegetables and a lot of the things that we historically have had, we just need to bring that back into our diets. A lot of the things we have now were never part of our historic diet in terms of fast food, in terms of a lot of the things, and even in terms of the way that things are being promoted to us by celebrities and these meals and things that are all based around very high fat diets. None of that's really truly African-American culture. So I would say that really focusing on behaviors and less on an individual may give us long-term, some benefits long-term.
Anybody else?
I just want to add to that. I think that is so excellent. When I'm talking to people about their health and they're talking about weight, whether they want to lose weight, gain weight, I tell them don't focus on the weight. Focus on eating healthy, exercising, sleeping, and then you're going to get to the place that you need to be. And so I think instead of focusing on body images, and we know that having excess weight is not healthy, it increases our risk for chronic disease, but I think maybe spinning it in a different way and helping people to understand how to be healthy instead of focusing so much on body image, and also just encouraging our women and men and helping them to have more of a positive self-image that's not based externally, but is based internally about who they are.
Mm-hmm. Brother Curtis, you have any comment?
Yeah, I think Dr. Naylor and Dr. Wells have kind of said it best. Body shaming is real, and social media, as great as a connector as it's been, the negativity of it has really promoted that type of body shaming and other type of let's say lack of confidence builders across our world as it stands right now. I think the other thing is just being a part, just like when you exercise, if you've never exercised before, being a part of some level of community and people who will push you in the right direction, give you that opportunity. I'm looking at the chat and Rodney White is continuously putting gems in the chat about plant-based Italian beef sandwiches and waking up with liniment water and sugar. I'm a big fan of using turmeric in the majority of the food that I cook for my family because, one, it's an anti-inflammatory, and two, it's healthy. So just continuously having those conversations about what is really good for your body and spreading that to others is really going to be the greatest step that we have, because we know, particularly in the Black community, we believe in each other more than we'll believe an outside source. So our word of mouth communication has always been best compared to having some, athlete or superstar telling us what to do. Because if Big Mama say, well, no, let's not use the lard, let's use, a certain level of olive oil or something, like anything like that, to just change that perspective and just change that lens so we have a healthier lens is what's going to move us forward.
Listen, we run out of time. I just want to thank each and every one of you for what you've done. I think this has been an excellent session. You know, as a pediatrician, and I want to put my bit in too, because each and every one of what you talked about has affected the population I serve, because I see more young people. I mean, I've had three 400-pound kids in my practice. I've had diabetics at 10, 11 years old because of diet. I treated more I was treating kids who were having adult diseases. Okay, maybe not so much with a cold. Oh, another thing, I've seen more Crohn's disease, inflammatory bowel disease now than I've seen before, that I didn't see in the early part of my practice. And I'm sure that's diet related as well. So like I said, it affects all of us at all stages of our life and growth development. So everything what you said affects not just adults, but children as well. So the parents, especially parents of mentees and children as well, all these things you do right now are going to affect your health later on. So it's really, really important. And that was about probably one of the most disappointing things in my practice. It's frustrating. It's frustrating. We deal with a population that's it's frustrating it can be frustrating, but we press on. And I just want to thank each and every one of you all for the parts that each one of you all play in helping healthcare, improving healthcare in our community. And I thank you for supporting the 100. And I just asked all of you others to please continue to stay with the rest of the sessions through the rest of the morning. And now you can go to the expo and check out some other things that are going on. And again, Dr. Wells, Dr. Naylor, Brother Curtis, thank you so much for being a part. Appreciate it very much. Thanks a lot. Bye-bye. Nice job, everybody. Nice job.
Thank you.
You're welcome. God bless.
You too.
All right. And please stick around and attend to some of the rest of the sessions as well. Okay?
Thank you. Bye-bye.
Thank you. Sharon? Sharon, you still on?
Yeah, I'm still here.
Whew. But you're right, Sharon. Whoever that other person was.
I'm talking to Eric now. Tell him to stay off.
So somebody and that person, whoever that.
That was one of the Collegiate 100. So Eric, I'll take care of it. Don't worry about it. I'll take care of it.
Comments are public.
Okay.
No, not now.
Okay. Here, Mike, call me now. Hold on.
Oh, that's right. Yeah. Like I said. Okay. Yeah.
Hey, Mike.
Yeah, like I said.
I'm doing fine. Good morning.
Somebody else may have come on, and that pushed me off. So.
Okay, go to reception. If you go to reception.
Okay. All right. Bye-bye.
Okay. Hold on a minute.